This is a visual we've been showing each of our practice short weeks, so it may be quite familiar to you now. It was put out in March of 2020, which I think I'm still kind of baffled that somebody had the foresight to imagine that this pandemic was going to have very significant waves outside of actual COVID-19. This is known as the need for a multidimensional strategy to address the care of older adults and their caregivers in 2019. And this is also available on our website. We've chosen to use this framework for our practice shorts. Each month we will focus on one of the waves, finishing up with the work of the North Simcoe Muskoka Specialized Geriatric Services and what we have done and continue to do during this time. The practice shorts will occur on selected Friday mornings at 8:30, and they will range in 30 to 40 minutes. As I said, the presentations will be recorded. Today we're focusing on the second wave of this graphic, the impact of resource restrictions on urgent, non-COVID conditions. At this time, I will pass this over to Tamara Nowak-Leonard to introduce our guests.
Thank you, Allison. For our first guest speaker this morning, I wanted to acknowledge the Central East Stroke Network for assisting SGS in organizing our first speaker. So our first speaker is Dr. Catanese, and she is Assistant Professor of Medicine at McMaster University and a stroke neurologist. And she is the physician lead for hyperacute stroke services at Hamilton Health Sciences. She completed her residency in neurology at Boston University School of Medicine, followed by a fellowship training in vascular neurology at Harvard Medical School. Dr. Catanese has participated in international trials testing novel therapies in acute ischemic stroke patients. She is the principal investigator of the National CVASC COVID-19 study and the OPERA and ACTION studies. She has received several clinical teaching awards, publishes regularly in peer-reviewed journals, and serves on the editorial board of the American Heart Association Stroke Journal. Most recently, she was selected as the new Stroke Fellowship Program Director at McMaster University. So welcome, Dr. Catanese. I have set up that you are able to share your slide presentation with us.
Yes, thank you very much. Can you hear me well?
I can hear you.
Yeah? Perfect. I'm going to share my screen now and put it on presenter mode. Just let me bring. I think that shows well, right? Is that correct?
Yeah.
Perfect. Okay, well, thank you for the kind invitation to participate today, your rounds, to talk about a really important topic that we have been learning about in just the last 6 months, which seems like 1,000 years. But the topic that I was asked to talk about is the impact of COVID-19 on the delivery of stroke care. So the outline of my lecture is as follows. I'm going to talk about the direct effects of COVID-19 just to understand how the indirect effects take place in this, and it has to do with the waves of infection. And briefly, that's what I'm going to focus mainly. And briefly, I'm going to introduce our study that is trying to answer some of these important questions. It's the only one in Canada doing so, and we're going to leave 5-minute time for some questions and answers. As you have heard already, there is a pandemic in the world caused by the severe acute respiratory syndrome coronavirus 2 that started back in December the 31st with the first confirmed case in Wuhan and has rapidly spread throughout the globe. Indeed, currently it's affecting 95% of the countries in the world, with over 28 million confirmed cases and almost 1 million deaths. Interestingly, in Canada, we have done very well. We actually are 26 in the world in terms of confirmed cases, with only 130, a little bit more than 130,000 confirmed cases to date. Now, the first, as the graph was showing, the first wave of pandemic and the first concern and focus from the entire public health and medical community was what is it going to cost the body? So that's the first direct effects of COVID-19, the ones that took most of the focus, at least at the beginning, and continue to take a focus of attention because we're now learning that it's a virus that not only affects the lung, but affects multiple organs, including the brain, and that actually have an increased risk of thrombotic complications, such as stroke, and it can increase the risk for stroke almost 1.5-fold. Because stroke is the leading cause of severe disability in North America, anything that can increase the risk and that is spreading quickly throughout a population, it's a public health emergency that needs a focus. So the thing is that there were all of these indirect effects also that took place almost at the same time as we tried to prevent the spread throughout communities, patients, and healthcare workers. So the indirect effects of COVID take place in patients, providers, and hospitals at different levels. So there are patients who avoid seeking medical care because of the fear of getting COVID-19 infection, and others that do want to seek medical care but had limited access to it because of the lockdown measures that took place in hospitals. There are providers that are overwhelmed with COVID-19, particularly in those hospitals that were at capacity, and then they decrease their efficiency to care for diseases that are not COVID-19. And the hospitals whose resource allocation and capacity underwent a major constraint, as they had to have about 80% of the hospital ready to be able to admit and take on this first wave of pandemic. There were many resources and many protocols that were in place suddenly after the emergency lockdown, particularly just thinking here in Ontario, but that took place in March the 17th. But it had to do with the use of protective equipment, physical distancing, and many other things that I'm going to show you in this next slide that had to do with preventing the spread of infection to patients and healthcare workers to be able to deal with this pandemic in the best possible way. So what are those system measures that were implemented very quickly? So there were very strong physical distancing measures, which we still have. We had to increase capacity, not only in the ICU, but also the hospital, redeploy staff to be able to, as you can see here in this graph, to be able to disinfect, sanitize, have available PPE, and all of those things. The other thing that happened is that our clinics will close, so the personnel needed to be redistributed, and the hospitals were in true lockdown. There was no access, there were no visitors, and that on its own takes a toll on patients, as well as time-sensitive diseases such as stroke, where having collateral information from a family member becomes essential at the time of treatment. So suddenly we saw this incredible phenomenon where heart attacks and strokes started to disappear from the emergency department, and nobody really knew why. Indeed, nobody knows exactly why that happened. Now, experts think that about 70 to 80% of these sudden disappearance, and I'm going to show you a little bit more as we move forward, is due to the fear of getting infected while going to the hospital. And that there is a percentage that has to do with the change in lifestyle, the lack of, or the reduction in stress associated with rushing, having to drive in rush hour, or the job in itself, or eating healthier because you can't just go to restaurants anymore and you have to make homemade meals. So several different things, but let me show you what happened. This is a graph that shows the number of patients that got imaging for acute stroke in the United States. before and after the pandemic. And you can see here that the collateral effect of COVID-19 in the United States was to drop 39% the imaging capacity or the delivery of imaging for acute stroke in just a span of a month and a half. This is the orange line shows the first statewide stay-at-home order. We replicated that in Ontario, and we collected data for 4,100 patients from 8 hospitals, and we found that there was a 44 decrease in the mean number of scans per center per month, which is a dramatic decrease. It's almost half of the delivery of stroke care in terms of imaging for acute ischemic stroke. This is showing data from Northeast Ohio, just to show you it's not only Canada, but what we are seeing here in this graph is showing you the COVID-19 period and how COVID-19 cases go up and the delivery of care goes down. This is the decrease in acute stroke alerts by 30% across emergency departments at the time of surge of COVID-19, and also the decrease of the delivery of telestroke capabilities, whereas the treatment allocation in terms of thrombolysis remain fairly, and thrombectomy fairly stable. If not, the thrombectomy had a little bit of a dip at the worst of the pandemic. This is on the other side, on Spain, showing that not only patients activated less the system, but also we had reduced admissions, 25% reduction in stroke admissions, and also 40% reductions in TIAs, pointing towards the fact that perhaps those patients that have minor deficits or that had transient deficits actually chose not to come into the hospital for evaluation, when it is, as you know, a medical emergency, and it's highly recommended that you come as soon as the symptoms start. Once you get to the hospital, what we did at the General in this study was to explore what happens to you when you actually come in and get treatment. Well, let me show you the first graph first. This graph is showing the door-to-needle times over the span of a year, starting from March 2019 to April 2020. What we saw is that we got slower. We doubled our times to treat patients with thrombolysis. And that was really heartbreaking to see, because our times right now, this month, went down to 25 minutes. So you can see how you can be affected. And when we look at the processes that take place during the giving thrombolysis, we found that the first point of contact, when you come into the emergency department and we take you to the scanner, that's the time where we were slow. And that was because of the lockdown restrictions. We had to show passes, put PPE, sanitize everything, and it took time for us to do all that. This is the similar data from Quebec, showing again, patients not only presented later, but they were treated later. There was a significant delay in imaging to needle and puncture to recanalization, which is endovascular treatment for stroke patients. And you can see the difference that is significantly different. So bottom line is that the public health and institutional restrictions imposed in response to COVID-19 can have a negative impact on acute ischemic stroke care metrics known to predict stroke-related clinical outcomes. You know that the more you wait, the worse you do. That's something that we know very well in literature. And not only that, but even when the patient came, we were slow. So there are many gaps in care that we need to address. We need to learn from this pandemic. The other point that we don't know is, if you have noticed, I just showed you what happens when the patient gets treated, but what about when they get admitted to the stroke unit? Do they get rehab? Do they get all of the resources that are consistent with the best practice guideline recommendations? We don't know that question. I can tell you our rehab for stroke closed down during COVID. So there were patients just sitting in the hospital, not getting rehabilitation. So that's why a group of colleagues, particularly my mentor and colleague from UHN, Dr. Picula, we started a national study looking at these two important questions in Canada. One, we want to characterize stroke in COVID-19 disease in Canada, and we're partnering with international projects to be able to answer this question appropriately, because we control the virus really well, so we don't have a lot of stroke cases in COVID-19, so we have to partner with others. But the most important thing the most important aspect is to determine the outcomes and the delivery of stroke care during the COVID-19 pandemic in Canada. We need to understand this more so we can be better prepared for second waves of pandemic or other pandemics in the future. This is the website if you want to take a look. And I'm just going to summarize by saying that the pandemic has had considerable effects on the delivery of stroke care. There are variations that are regional, certainly, but the overall patterns is that there are less stroke assessments, less admissions, the patients present late, and there are greater delays for reperfusion treatments for stroke. And our study funded by the Canadian Stroke Consortium will characterize the impact on delivery of stroke care in Canada for the first time, and we really need to understand that. Thank you very much, and I will open it up for questions.
Thank you so much. That is so interesting. Now, I haven't been following the chat, but certainly if anyone has any questions, you're certainly welcome to voice them, or if Allison or Kim have questions that have come up on the chat box.
There's been no questions, Tamara.
Okay, well, thank you, Dr. Catanese. It's very interesting, and actually look forward to your publication and the findings from your study, because unfortunately, I think you'll probably find that there has been decreased in care and rehab, which is unfortunate, being a daughter of someone who has had a stroke and understands the importance of that aspect of care, stroke delivery care.
Absolutely. Thank you very much.
Thank you. Sorry. So our next speaker is Dr. Bingham, which our staff from the Specialized Geriatric Services will be familiar with. So Dr. Bingham is a staff psychiatrist at the University Health Network Center for Mental Health. She is an assistant professor of the University of Toronto Department of Psychiatry. And of course, she is one of our staff psychiatrists with the North Simcoe Muskoka Specialized Geriatric Services. So welcome, Dr. Bingham. Oh.
No, sorry, I was just on mute. Great. All right. Thanks for having me. Good to see everybody. I think I know a lot of people here, of course, but thanks for the introduction, Tamara. So I'm just going to share my PowerPoint here, or put it in presenter mode, I should say. Okay. Tamara, can you guys see the slides?
No, not yet.
Oh, okay.
Can't see the slides, no.
Oh, I don't know. Do I have the screen share?
I do have screen share. You should be able to.
Okay. Share. Oh, there. That's the problem. I hadn't actually shared it. I thought I did. Sorry, I was on call last night. So,
I heard. Thank you.
No, it's okay. Well, it's not always that busy, but last night it was. Okay. So. Okay. Now you guys should be able to see, eh? Perfect. All right, so I was asked to discuss the impact of the COVID-19 related resource restrictions on geriatric mental health. And so that's a topic that certainly we're seeing, or that's very relevant in, I'm sure everywhere, but certainly in the North Simcoe Muskoka community that I'm working in. I would agree with the point made earlier by Dr. Catanese that really we hadn't initially, just anecdotally at least, been seeing a huge a huge sort of surge in cases or an increase in cases at the early part of the pandemic, but I would say over the last month or two, I've probably been busier than ever with a lot of, especially inpatient referrals from people who just haven't been managing in the community. So was going to talk about some of that today. I don't have any conflicts that are specific to this presentation. I think I've already mentioned that the objective is to discuss the impact of COVID-related resource restrictions on geriatric mental health with a focus on more urgent conditions. I did want to start just by giving an example of a case that I think illustrates some of the points that I wanted to talk about. So this is a case of a lady, an 82-year-old woman with Alzheimer's disease, moderate severity, who is managing well at a retirement home, but with extensive support from her daughters, who don't live in town but are very involved. I know her already, but she had been doing fine when I saw her a few months ago, and I was asked to assess this more urgently for significant depressive symptoms. So some of these included low mood, anxiety, low energy, low motivation, and really just not functioning very well compared to her baseline. So really it was, as we've been seeing time and time again, due to a cascade of events that really started with the COVID-related restrictions. And I've illustrated a bit of a schematic here. Obviously it's, there may be other causes too. It's not definitive, but just to kind of give an idea of what might have led to her depressive symptoms. So I think there were three things related to the restrictions in the retirement home setting. One was was having meals in her room rather than going down to the dining room for meals. This led to poor oral intake, so she would just forget to drink and wasn't being supervised. So she ended up getting dehydrated, developing a UTI, and then associated with that, she was hospitalized, had a loss of her energy, motivation, that sort of thing, just related to the physical illness. The second, and probably maybe the most important one, although it's hard to obviously say for sure, was the inability to visit with family. So this was a big part of her life, obviously. She could still talk to them, but wasn't seeing them in person for a number of months. And so that, of course, along with not being able to go down to the dining room for meals, along with also her having to stop playing the lounge piano, which was a big part of her social life and her self-esteem, and it sort of tied her back to her something that was very important to her earlier in life, led to that reduced intellectual and social stimulation, led to decreased confidence, kind of in a vicious cycle. And I think that also contributed to her loss of energy and motivation. And so all of these things combined ended up causing her to have these depressive symptoms. So in the end, she actually, once things had opened up again, and I kind of spoke with her and her family, and we talked about strategies to get her going again in terms of that stimulation. By the time I saw her again this week, actually, she was back to her usual self. So that was a positive ending, although we've been seeing a lot of people who maybe just don't have the same resources or the same, who maybe have a more serious illness, not the same type of supports, who just don't get back, unfortunately, to their baseline. So it's certainly been a major issue that we've been seeing. So specifically, what acute issues are we seeing? And now a lot of this is anecdotal based on my experience and experiences of colleagues. There are starting to be publications, but not enough to have a lot of data yet, although certainly that's forthcoming. But anyways, what we're seeing clinically is a significant worsening of cognition and functioning in older adults, usually with cognitive impairment, along with the loss of ability to manage in the home environment. So people who are kind of hanging on with the resources that they had in the community are just no longer able to manage and basically have ended up in hospital. Along with that, there can be worsening, so in dementia specifically, worsening of the behavioral symptoms of dementia. This may often be in the setting of long-term care, but could be in community or retirement home as well. So basically with that loss of their usual supports and social stimulation, there's this just overall worsening of the behavioral symptoms when people's needs aren't being met. So this would include things like psychosis, aggression, severe agitation, depression or apathy. All of these, again, are leading either to significant distress or functional impairment or to hospital admissions. As part of that, we're also seeing a lot of caregiver distress and burnout, which again, people not being able to manage at home with the loss of their usual supports like day programs, for instance, means that caregivers are no longer able to manage and are going into crisis. Okay, so this is not specific to mental health, but I did think it was a good illustration of some of the challenges that we are having in the mental health system, where there were a lot of pre-existing issues in the mental health system in general, as well as in the long-term care system and in the community care system for older adults. So a number of resource related challenges, and then COVID was kind of the thing that tipped the balance. And in this case, it's showing it as an anvil falling on top of this nurse, it looks like. So I just thought it was a good illustration of the, you know, existing challenges, and then COVID coming in and making things much, much worse. Okay. So speaking of that, really, the crisis that we're seeing right now, obviously there are a lot of things that are underlying it. So there are risk factors that at both a system level and a patient level that are playing a role in the crisis that we're seeing now. And so some of these, it's not exhaustive, but some of these might include, from a system perspective, just the chronic underfunding of seniors' community programming and the long-term care system. Inadequate access generally to mental health resources, so not specific to seniors, but certainly a challenge for them as well. Then, of course, there's the social stigma regarding aging and mental health conditions, which may be contributing to the underfunding. And I think one of the important things that we've really realized, but it's kind of coming, we realized a little bit before, but it's coming to the forefront now, is the lack of recognition of really the vital role for family caregivers or care partners, family or friends. Really illustrated a lot in the long-term care and hospital systems, but, you know, certainly playing a role throughout. And then in terms of patient factors, so of course, people with pre-existing vulnerabilities like mental health conditions or physical health conditions are at risk for COVID-related crises, or well, COVID-related, not COVID-specific crises. Social isolation and loneliness. So we know that that's a major risk factor for mental health challenges. I don't think we necessarily realized as a society, though, how much it is a risk for some of these challenges, not only for mental health, but for health in general. And also the effect of isolation and loneliness on people who actually were previously well supported and then had that taken away. And then, of course, the other factor that could lead to a crisis would be the presence or absence of caregiver resources in coping. Okay, so these are some potential solutions that have been sort of discussed within, you know, the seniors, mental health, and geriatric community. Again, not exhaustive. So at a systems level, again, recognition for the need of continued involvement of family caregivers in long-term care. So really is not going to be feasible to fully lock down long-term care again without allowing family caregivers access. We've seen the detrimental effect that has on the health and well-being of older adults in long-term care. Again, the gradual and, you know, within public health guidelines, reopening of in-person community resources. So a lot of seniors are accessing virtual resources, but a lot of them are not able to. And for a lot of them, there's really just no replacement for the in-person resources. Stronger collaboration between community and hospital resources in long-term care. And then support for seniors in accessing technology for virtual care or virtual support. From a patient perspective, things that caregivers and other healthcare professionals and people who are in support can do would be proactively checking in with patients and caregivers who you know might be at risk because of isolation and limitation of resources. Inquiring specifically about caregiver distress, since it usually is part of the picture, especially in people with dementia. Involving community resources early to combat social isolation as much as possible. So somebody who maybe was managing fairly well before without a lot of resources may need those resources now that they just have less in the way of support because of COVID. I think also what at least I've personally been doing with a lot of patients, because older adults are often afraid of getting COVID, is discussing really the risk and benefit of the potential exposure when they leave the house and engage with people socially versus their risk from, you know, not having access to those usual supports. So the risk on their general health and well-being. And of course, that's an individualized decision. So there's no right or wrong answer for everyone. Okay. So I did allude before to, the lack of data yet, which makes sense. I mean, this has been going on for a while now, but not for that long in the grand scheme of things. So there has been a call in our main journal, the American Journal of Geriatric Psychiatry, for studies, both anywhere from case reports to larger randomized controlled trials, looking at the impact of COVID-19 on mental health and aging. So I think in the coming years, we'll have a lot more information about it. Okay, and so that's everything. So I'd certainly be happy to take any questions or comments that people have.
Thank you so much, Dr. Bingham. Does anyone have any questions or comments?
Dr. Bingham, this is Ablash, psychometrist with the SDS. Can you hear me?
Yes, I can.
Just wondering, just so one side, when we talk about COVID-19 and its impacts, definitely it has an impact on lack of staff. As you said, there is already kind of a shortage of staff and a lack of infrastructure support, all kinds of systemic issues there, right?
Mm-hmm.
So then, with the COVID-19, then again there is not a lot of staff and other support. So do you think there is any correlation between that will increase the use of PRNs and psychiatric medications to manage behaviors?
I think so. I mean, I think that's something that will be good to look at, from a more systematic perspective, because one could definitely hypothesize that it would be for a number of different reasons, that you've already alluded to. So I think we're really realizing how much people rely on. I mean, it makes sense, of course, we all need social connection and stimulation, but how sensitive people with dementia who are institutionalized are to any loss of that social stimulation and activation. So as a result, they're having all of these increase in behavioral symptoms to, communicate need. And because of that reduced staffing, which I think it seems, at least in the homes I work in, it seems like maybe it's a little bit better now than it was earlier in the pandemic, but still a challenge. It has always been a challenge. It's not only because of COVID. So really the only option for people with severe symptoms is PRN medication right now. So I think it would be a good thing to actually to look at, to study, and I suspect it will be done. So we'll see.
I agree. It will be a good opportunity to study the effectiveness of PRNs and in this kind of a situation and the quality of life and those kind of stuff. But
yeah,
it is a challenge for sure.
Absolutely. Yeah, no, it's a huge challenge for that. Yeah. And I think we knew it would be. And we were seeing it, I think initially in long-term care, we knew that was the setting that was really hit the hardest, but that certainly still is the case, but we're also seeing it now in people from community and from retirement homes. And for them, because they are not in long-term care, they have nowhere else to go. So they go to the hospital and then they're ending up either staying there for a long time or going into long-term care. So, my referrals from the inpatient units has just probably tripled in the last month or so. It's, it's always busy, but it's busier than ever.
Thank you.
Hi, it's Karen here. I'm just, your slide on sort of your recommendations and what we should do is very compelling. And I'm just wondering how that is being disseminated at levels where these decisions are being made that have such a big impact on the seniors. And, what role do you and do we have in that?
So, I mean, someone in leadership here, I don't want to put her on the spot, but for instance, Sandra might be able to speak to that a little bit more from a leadership perspective in North Simcoe, Muskoka. I can say that sort of more broadly, there are several working groups and advocacy groups from, incorporating people in geriatric mental health or not only mental health, but geriatric mental health, advocating for both at sort of a local and regional and provincial government level on some of these things. I can't, I don't know all, I don't know everything that's going on those. So it definitely is happening, but I think we'll see kind of the effect that it has on the government, because it obviously has to come from the top in terms of funding and planning. So I don't know if anyone else has more information about that than I do, but that's I am part of one of the working groups anyway, so I have access to some of that information there.
So, yeah, I mean, even, allowing family caregivers to continue and, that doesn't actually require any additional funding.
Yeah, that's true.
It's just, yeah. And I think like your case, probably everyone at this, on this meeting has similar stories, right? And similar cases of how that downward spiral happened, and how we can, even small things to prevent that from worsening.
Yeah,
So,
no,
yeah.
Really,
I just wanted to say thanks, both presenters. It's very, it's so important, and it's great that, the impact on stroke is being formally studied, and then that can, have a lot more power to affect change and educate and so on. So thank you.
yeah, no, for sure. When you have the data, that's really is needed to, to move things forward. I think it's true, but I think, it's a good point at an individual level too, like a smaller level. What can we do? And I know that reminded me that one thing that I was doing more so earlier when visitor restrictions were even more limited, but that may happen again, was advocating basically for every patient I saw that they have a family member allowed to visit as an essential visitor or care partner. Like as part of my suggestions, it would be like the first thing in terms of almost like a prescription. And I think that for a lot of people that was helpful. So that's like a small thing that I didn't mention, but I think it makes sense. And then needs to be pushed for at a higher like policy level too. I mean, there was so much media on the effect of family being left out of long-term care that hopefully it won't happen again to that extent, but we'll have to see.
And it's even the hospitals as well. Like I have, a family member who needed to have an appointment, and her daughter needed to go with her, but she was worried she wouldn't be allowed to go. And it's just like around educating around the language to use. So I told her to say, "You're an essential caregiver," and they let her go. Mm-hmm. Right? Mm-hmm. So even those little tips, I think, can be helpful for family members who feel a little, at a loss or left out.
Yeah, that's a good point for sure. And yeah, people like it's helpful for people to kind of learn how to advocate in the language to use.
Yeah.
And Dr. Bingham, I really appreciate your discussion on educating and speaking with patients and families about the risks and benefits, specifically in regards to the physical distancing and requirements. And so having that discussion, allowing them to make those decisions, I think is really vital for us as care providers to be able to discuss that with our patients and family members, so that they can make informed decisions and understand the risks that might accompany not actually going out, doing some of the activities that they used to enjoy.
Yeah, oh, absolutely. And I think it is improving just with the summer and the kind of reduced, like opening up of the, economy and society a little bit more, but it's still, a lot of people are just so afraid of, understandably, of getting COVID, that they're actually causing themselves more problems in terms of their, mental and physical health. So it's, and especially in regions where the prevalence isn't high. I mean, I don't want to be telling someone, oh, go to a party, go, don't worry about it. But like more making sort of informed decisions about like how risky is it to do this versus what is the actual risk to your health. And I think that, people need to get somewhere like to be given a platform to be able to think about that a little bit more for, make decisions that way.
Mm-hmm. Mm-hmm. Absolutely. Is there any other questions for Dr. Bingham? Okay, well, if not, thank you so much, Dr. Bingham, and I will let Allison take over.
Thank you.
Did I unmute myself? Sorry, I'm having technical issues today. Thank you so much to the presenters. I know that we've all gained some valuable information today and some insights into this pandemic and the multifactorial component to not only the pandemic, but to our possible solutions. Having looked at the chat box, I know both presentations absolutely resonated with the audience, and certainly on trend with what people are seeing in their roles as well. I know that we can all think of individuals that we're supporting who are directly impacted by COVID in terms of their urgent non-COVID conditions. So I really appreciate both of you for presenting and being so, it's so timely as well. I wanted to draw your attention to the fact that we are going to be doing another practice short on October 9th, looking more specifically at the third wave of that graphic, the impact of interrupted care on chronic conditions. That will be at 8:30 in the morning on Friday the 9th. The current practice short will, as I said before, will be available on the North Simcoe Muskoka Specialized Geriatric Services website, probably within the week. The recording will be there. We also wanted to draw your attention to our upcoming Dementia Network Conference, which has changed in its nature this year. It's normally the last Wednesday of October, a full day event with catered and everything. This will not be catered. We're going to be doing 3 separate virtual sessions, starting on October 14th with Dr. Petal Abdul. October 21st, we will have the privilege of having Dr. Bingham present for us. And then finally, finally with Dr. Cassidy. The concept of this year's conference is optimizing health for all, those living with chronic conditions as well as those caring for them. There is a registration link that can be found on the Alzheimer's Society website as well. If you need information, please contact your PRC and we will definitely get you set up with a registration. Thank you very much and have a wonderful weekend.